Welcome back, auditors and coders, to this explainer. Today we're taking a really close look at two of the absolute most misunderstood categories of moderate complexity within the MDM table. If you've ever found yourself just staring at a provider's chart, scratching your head, wondering if a brand new symptom actually hits that moderate level, or if a patient's fever genuinely qualifies as a systemic illness, well, you're in exactly the right place. Let's get to work.
Okay, let's dive into this. Here is our roadmap for today. We're going to start by decoding MDM complexity, then we'll explore undiagnosed new problems and the differential diagnosis rule. After that, we'll shift gears to acute systemic illnesses, compare high risk versus minor symptoms, and wrap it all up with a really practical auditor's checklist.
All right, Section 1, Decoding Moderate Complexity and Navigating the COPA Table.
So when we're looking at leveling a visit as moderate complexity under the AMA and CMS guidelines, it is absolutely not a guessing game. As an auditor or coder, you can't just kind of feel out the complexity based on how long the note is. It requires precise clinical decoding validation. The documentation literally has to identify specific risk factors and point directly to the definitions in the MDM table. Today, we're stripping away the confusion around two very specific moderate-level problems to show you exactly how that validation works in the real world.
Moving on to Section 2, Undiagnosed New Problems. This is where the detective work begins.
Now, according to the strict AMA definition, an undiagnosed new problem with uncertain prognosis is a problem in the differential diagnosis that represents a condition likely to result in a high risk of morbidity without treatment. That's a bit of a mouthful, right? But the absolute crucial phrase to zero in on here is without treatment. The uncertain prognosis isn't just about the provider saying, I don't really know what this is. It specifically hinges on the fact that if this condition were left untreated, there is a high risk of morbidity. The provider is looking at this brand new mystery symptom and actively thinking, could this be something severe?
Section 3, the Differential Diagnosis Rule, or as we should probably call it, intent over outcome.
So, the crucial point to remember is that the differential diagnosis has to include a condition with a high risk of morbidity without treatment. Just let that sink in for a second. As auditors, we are evaluating the physician's diagnostic intent at the exact time of the encounter. If a provider is actively working up a patient to rule out a major, high-risk threat, the ultimate outcome of that workup, even if it turns out to be completely 100% benign, does not downgrade the initial cognitive complexity of the visit. You level based on the workup and the differential, not just the final diagnosis.
Let's look at a specific clinical scenario breakdown straight from our guidelines to illustrate this. Picture this. Step 1, a patient comes into the office with a new breast lump. Step 2, the provider evaluates this and documents that the differential diagnosis includes malignancy, which prompts them to order diagnostic imaging or a biopsy. Step 3, even if that lump ultimately turns out to be just a completely benign cyst, moderate complexity is validated for that initial encounter. Why? Because breast cancer was a legitimate, high-risk condition in the differential diagnosis that required serious investigation. The physician had to do that complex detective work to rule out a major threat.
Let's move to a second clinical scenario and see how this builds across different body systems. Step 1, a patient presents with acute unilateral leg pain and redness right after a recent procedure. Step 2, the provider assesses the patient and orders an urgent Doppler ultrasound. Step 3, because the provider is actively trying to rule out a deep vein thrombosis, or a DVT, this equals moderate complexity. The logic is exactly identical to the breast lump scenario. The provider is looking at an undiagnosed new problem where the differential holds a highly morbid, potentially dangerous condition.
And, this detective logic applies to a whole variety of presentations. The source material outlines several other high-risk presentations where the physician is actively investigating a potentially highly morbid condition. We're talking things like undifferentiated chest pain, acute shortness of breath, unexplained enlarged lymph nodes, acute severe abdominal pain, a potentially septic joint, or severe edema. If the documentation shows the provider is working up these symptoms because a high-risk diagnosis is actually on the table, you are looking at an undiagnosed new problem with an uncertain prognosis.
Okay, Section 4, Acute Systemic Illnesses, Identifying the Threat.
Let's shift our narrative now from the detective to the threat. In this category, the mystery is largely gone, right? The patient is dealing with a clear, established systemic danger. We're talking about an acute illness with systemic symptoms. The definition here is an illness causing systemic symptoms, which, by the way, can affect multiple body systems or just a single internal organ system, and has a high risk of morbidity without treatment. A super common misconception among coders is that systemic always has to mean a total whole-body shutdown. But notice the definition clearly states it can be a severe threat to just a single vital internal organ system.
Section 5. High risk versus minor symptoms. This is the critical distinction right here.
And this brilliantly illustrates the strict dividing line we have. High-risk systemic illnesses include severe conditions like pyelonephritis, pneumonitis, colitis, meningitis, and early sepsis. These are serious conditions with a high risk of morbidity if they're left untreated. Now contrast that with minor systemic symptoms. Here, we're talking about things like a low-grade fever, some body aches, or fatigue happening during a self-limited minor viral illness, like the common cold. The distinction is all about the inherent danger of the underlying illness itself, not just the mere presence of a widespread symptom.
Let me pause right here and ask you a direct question to test your knowledge on what we just covered. This is our auditor caution callout. If a provider documents that a patient has a fever, does that fever automatically elevate the visit to moderate complexity just because it's technically a systemic symptom? Think about the intent of the guidelines we just went over.
The answer is a resounding no. Absolutely not. This is a trap that is just so easy to fall into. Treating minor illness symptoms like a fever, fatigue, or body aches simply to alleviate the patient's discomfort or maybe shorten the course of the illness or prevent minor complications, well, that does not equal moderate complexity. You cannot automatically uplevel a self-limiting bug to an acute illness with systemic symptoms just because the patient's whole body happens to ache. The underlying illness itself must pose a high risk of morbidity without treatment.
All right, final section. Section 6. The Auditor's Checklist. Validating the documentation.
Here's what you need to take back to your desk today. This is a practical 3-point summary checklist to really lock in these rules for your daily auditing work. Number 1. Always identify all conditions that were actually managed or addressed during the visit by the reporting provider. Number 2. If you see an undiagnosed new problem, validate whether the differential diagnosis actively targets a high-risk condition. Remember, it's intent over outcome. And number 3, when dealing with acute illnesses, strictly differentiate true high-risk systemic illnesses from minor self-limiting viral symptoms. Honestly, if you stick to this checklist, your moderate complex leveling is going to be rock solid.
But you might be wondering, what happens when the problem isn't an illness at all, but a massive physical trauma that spans multiple body systems? Does the mere presence of multiple injuries automatically skyrocket the complexity? Well, up next in Part 8, we are going to tackle exactly that in acute complicated injuries and multi-system evaluations, navigating high-risk trauma. We'll see how trauma further complicates medical decision-making. Until then, keep your audits accurate and your clinical context sharp. Thank you so much for joining me. And as always, this has been Decode Healthcare with Harshal. See you next time.